Well, good afternoon, everybody. Welcome to NATA's Private Aviation Online Forum. I'm Ryan Wagasback, Senior Advisor to the National Air Transportation Association. And I'm thrilled today to begin our talks with key people in the industry. You know, we did this during the pandemic and it was fantastic. We brought everybody together. We talked about real issues that were happening in the marketplace, whether you're a charter operator, an FBO, an airport, repair station, and said, you know, we just need to address these. We want these to be open forums and open times for people to discuss things that they're seeing. Today, I'm thrilled to have Dr. Greg Pinnell, President of AirDocs, Aeromedical Support Services, a multi-specialty group providing a variety of services to the aviation community. Dr. Pinnell has had over 20 years of aviation medicine experience and has been a pilot for the past 40 years. You don't look a day over 30, Dr. Pinnell.
I feel it though.
So again, today we're going to be talking about one element of human factors, and that's mental health. You know, we've been going through so much activity, our cadence within our industry post-pandemic. During the pandemic, we were still out there, we were still running essential air services, providing, you know, lift, fueling aircraft, etc. And I think it's an area that we need to address. What are we doing? What happens if your you know, key team members, pilots, etc., come to leadership? And that's why I thought it was important to bring Dr. Pinnell in to discuss, you know, what are some trends, what is he seeing, and what are some solutions? So Dr. Pinnell, thank you.
My pleasure, and thanks for having me. Yeah, this is one element we're going to talk today about. We're going to talk about essentially one element of basically of human factors. And, you know, for those of you operators out there who don't necessarily employ pilots, these general things that we're going to talk about, they actually run across the gamut of employees and the like. You know, we have multiple employees at our company as well, and of course we pay attention to these things as well. So without further ado, and make sure that we have time for any questions, I'm going to share screen and we're going to run through this presentation. So let's get this to work. All right, very good. So what we're going to deal with one aspect of basically of human performance, and you know, so we're going to deal with mental health and returning to flying. And again, this can work for non-pilots too. My credentials are down there. Now, on background, and Ryan said it very well. I mean, this pandemic and the decisions and the things that we've had to do to adapt have placed a huge impact on society. You know, 10 years from now, when the sociologists take a look at this, they'll say we probably did some things right, we did some things wrong in this thing. And, you know, of course, the Monday morning quarterbacking will occur. The thing about mental health and stressors that some people are better to adapt than others. For some, this pandemic has just been well, this is an inconvenience and I've got to wear a mask on my flight. Unfortunately, some people don't handle it quite as well and it can overstress them. You know, and unfortunately in the aviation industry as well, we have had a couple of student pilot suicides. Now, if they're directly related to the pandemic or underlying mental health problems is of course, you know, up to question. But there's been some big carriers too that have had problems with mental health in the cockpit too. For example, Germanwings. Obviously, everybody knows about that one. We'll talk a little bit more about that as we go along. Egypt Air, and even more recently than that, the China Eastern accident, which certainly is apparently has been a suicide by aircraft. The bottom line of all the various different human factors affecting, for example, the FAA medical, there's probably nothing that raises more fear with pilots than mental health and grounding. And what will this do to my FAA medical? This is due to a combination of things. The fear out there is obviously part of its lack of knowledge of mental health and how the FAA handles it. Lack of knowledge of treatment resources and what is allowable and what's not allowable from a medical certification point of view, what's allowable as far as medications are concerned. And unfortunately, the internet, God bless it, has provided us with a lot of and unfortunately sometimes disinformation, and a lot of what our doctors do in our practice, and we have 11 flight medicine physicians in our group. We deal a lot with misinformation, intentional misinformation, and unfortunately that doesn't make it any easier. Now, we've all had, for those of you who are in the have a private pilot license or above, we've been dealing with this thing ever since we were a student pilot called I'm Safe, and it's an acronym which basically helps us determine whether we're fit to fly on that given day. And the I'm Safe stands for illness, medications, stress, alcohol, fatigue, and the last one's had a couple different words attached to it, emotion or eating. I teach this to my Western Michigan University College of Aviation students too. But for today, we're going to basically comment on the stress and emotion. So what are we going to discuss? All right, we're going to take one specific mental health diagnosis, actually one of the easier ones, and I'm going to walk you through it, how the FAA deals with it, how it manifests, how the natural course of the disease is, how it's treated, how it's resolved, and then how we get that person back on flying status with the FAA. And if this is a non-flying employee, like a flight attendant or a line worker, possibly how we get this person back to return to work. For those of you who are pilots, we'll talk a little bit about how your AME can handle this, and we'll talk a little bit with respect to the German wings, and this will apply across a broad swath of different types of aviation businesses. The result of the aviation rulemaking committee that happened after German wings and what we found out after studying the German wings accident. So, like I said, let's take an easy mental health diagnosis, adjustment disorder. Now, what the heck is that? An adjustment disorder is a stress event and response, okay? And it can be negative, but it can also be positive. It can be, I'm having financial difficulties, or maybe it can be, I've had a new job, which actually can seem to be a positive, but it overwhelms us. This is a pretty common mental health diagnosis. There's greater than 200,000 events of this in the United States per year. Now, what it means is basically whatever happens to us or whatever has happened to us is overwhelming our coping mechanism, and it breaks us down and it makes us not as functional. So what are the common symptoms of it? Well, they're in front of you on the bullet point. What we call hopelessness, anhedonia, which is a fancy Latin way of saying, hey, we don't like to do the things that we normally like to do. And you can look at this in a pilot or look at this in an employee and say, hey, you know, man, he's usually out working out, you know, he's riding his bike, he's doing whatever. And all of a sudden, for some reason, he stopped doing that. That's a worrisome sign. Excessive worry, sleeping difficulties, problems concentrating. All of a sudden, that pilot's behind on the radio calls. They're just not sharp with the aircraft. Or that line guy in his fueling of aircraft all of a sudden is making dumb mistakes that he doesn't normally make. Difficulty functioning, just basically generally difficulty functioning, and possibly even in the worst cases, possibly suicidal ideation or thoughts of self-harm. Now, with adjustment disorder, we have various different flavors. We in medicine we don't like to just make diagnoses. We like to also make different flavors of the diagnosis, and this one's no different. We have adjustment disorder with depressed mood, in other words, they're depressed, with anxiety. We have disturbance of conduct. And what is that? Disturbance of conduct is where all of a sudden that person who's normally pretty easygoing or at least tolerable, all of a sudden their conduct is getting out of line and you're going, what the heck is going on with this person? Or it can be mixed. So that defines out what an adjustment disorder is. Now, who winds up diagnosing it? Well, sometimes sometimes these things will happen. They'll resolve themselves over time, and they'll never get to a diagnosis. But sometimes they're diagnosed by a physician or a physician extender, such as a nurse practitioner or a physician assistant. Honestly, I would think in 2022, probably more of these are actually seen by nurse practitioners and physician assistants than by physicians. Sometimes seen by psychiatry up front, but that's pretty uncommon. Most of the psychiatrists are hard enough to get into. The person usually winds up reaching out to their primary care for the purpose of diagnosis of this. Now, what's important here in that third bullet point you're looking at, from the perspective of return to work or definitely return to flying status, is what we call proper diagnosis or diagnostic accuracy, okay? Because like a lot of different things, physical conditions, this is one, a mental health condition that needs to be differentiated out from other things. And sometimes in the beginnings of it, it can be hard to tell which it is. We need to differentiate it from something a little bit more serious, such as example of a major depressive disorder event, okay, or possibly what we call a personality disorder, where the person is acting out and it's basically a manifestation of their underlying personality, or post-traumatic stress disorder or PTSD. You know, some people like to hold stuff close to the chest and they don't tell you what's just happened in their family. Abuse, something like that, something really bad happening, and they're having PTSD from it, but they're not sharing it with anybody. They're getting the symptoms of it, but they're not telling anybody. So diagnostic accuracy is extremely important here. Now, bereavement such as a loss of a parent, as an example, that's excluded from this. That is its own category, but so we don't have to worry about that in this case. All right. So important points here for either the FBO operator, the 135, the 91 operator, the pilots union, is that we need to note the fact that, remember, like I said, diagnostic accuracy is extremely important. Well, one of the things that we find out about in primary care, and my board certification is in family practice, is we have a tendency to downgrade the diagnosis. In other words, we don't do a fantastic job with diagnostic accuracy. We may call a major depressive disorder, which is a pretty serious event. We may, it's just an adjustment disorder, and we may be wrong. We also have to look at what we call comorbidities. We have to hone in a little bit. We have to dig and find out, hey, what else is going on? Is there family mental health problems? What's the genetics of this person? What's their underlying personality? And also, what kind of environment are they living in? Do they have a supportive environment? Do they have a toxic environment that's making everything worse? But if it's an adjustment disorder and we get it right, whatever treatment we decide to use for it, it should get better and it should respond to the treatment. And we'll talk a little bit about treatment next. So how will we treat it? This is a thing that probably freaks out pilots, as an example, probably more than anything, because they're absolutely terrified of the fact that if whatever the condition is, if they treat it, oh my God, I'm going to be grounded for life. Will I ever get back to flying? If I had a nickel for every time I've heard that, if I go to someone to get treated for this, will this mean I'll get grounded forever? Generally, the answer to that, and most times the answer to that is no. Even more so, probably the faster you get to treatment, the faster this will get better, and the faster you will get back to flying. So how will we treat it? Well, there's psychotherapy, sometimes what we refer to as cognitive behavioral therapy. There's EAP programs, which are employee assistance programs, social support, and friends, obviously. Sometimes even short courses of antidepressant medications or anti-anxiety medications may be used. They may be used properly, and they actually may shorten the course of this particular diagnosis. In many cases, also faith-based programs are helpful for those who are inclined to go that way. There can be a lot of support there. So there's a lot of different treatment modalities for this particular adjustment disorder diagnosis, and generally they make it get better faster. So how long is it going to last? How long are we going to have to deal with this? Well, by diagnostic criteria, by the definition of adjustment disorder, it must appear within roughly about 1 to 3 months of the stressor. So whatever bad or good happened, it needs to show up within a couple months. And in general, it must resolve within 6 months of the cessation of the stressor. In other words, the stressor goes away. You got used to your new job. You lost your job. You found a new job. Whatever bad happened or whatever was overwhelming you has gone away. And you know, the human species, we're pretty resilient. We bounce back and we get better. So it should ultimately resolve, and that is the expectation. And also, that is the thing that we always try to reinforce to the pilot or employee, that look, if you treat this, okay, and we're accurate with the diagnosis, this is going to go away. All right, so important points to the employee or the pilot. Okay, first of all, don't hold back. All right, you get in, you see somebody, don't hold back. You need to give the person a complete history. We need to get that diagnostic accuracy to make sure we're on the right track. It's going to be in everybody's self-interest if that happens, including the pilot and the return back to flying. For the primary cares, we also suggest that don't feel bad about referring to psychiatry. A lot of us don't like to refer out because we know how busy they are. We know how hard it is to get to somebody. But in the case of the employee, the employer, or the pilot, don't be afraid to recommend, hey, you know what? We need to get you into an A-team player here. Let's get you into psychiatry if there's a doubt about the diagnosis, because that's the job to really nuance that. If you're dealing with a provider, and we have to, on the AME flight medicine side, we have to stress to the provider that, look, hey, you can't just see this person once and then see him again in 6 months, okay? You're going to be needing to see this employee or this pilot. You're going to need to be seeing them on a monthly basis, all right? Through the end of this, we're going to need good documentation, and it's going to need to be complete, because we're going to have to make a case to the employer or the FAA that this person is now fit to fly. Also, in this particular diagnosis, we need to stress to the provider, whether it's psychiatry or primary care, we need to stress to them that we're going to need at least 90 days if they put them on medication. We're going to need at least 90 days after that medication, and then we're going to need some pretty good testing from them in the forms of screening exams and good office notes before we can start working this person back into the cockpit safely. Documentation is key, and it must be complete and it must be accurate. So in the case of those of you out there who are pilots, how can your local AME handle this? Well, some AMEs like to deal with this. Some AMEs don't like to deal with this. Some AMEs are very good with this. Some of them like to just turf it off to the FAA. Well, what's important for the AME is to get the documentation, or what sometimes we call the current status reports, and promptly get them into the Air Medical Certification Division at FAA for review. We also need to make sure that the pilot has an unexpired medical exam in the system for FAA to work with. We've run into that problem before, where their pilot's license, or not their pilot's license, their medical actually expired 3-4 years ago, and we had to bring them back into the office for an exam because it didn't dawn on us they didn't have a current exam. Now, in some cases, and there's a lot of caveats here, a really experienced AME with the appropriate documentation and using the AME guide could either handle this themselves and issue, or call into one of the physicians of the day at Oklahoma City or the regional flight surgeon's office and get verbal authorization to issue. The AME guide does allow for that, but boy, we treat that with a lot of caution. At Western Michigan, we have been lucky. We've had a couple of the aviation universities who had suicides by aircraft. Knock on whatever this is, we've not had that, but unfortunately a couple months ago at our main campus, non-aviation part of our campus of Western Michigan University, we had a couple of South Korean students who committed suicide in relatively short succession. So this has got to be handled very, very cautiously, and it's always a good idea to get another set of eyes looking at it. It would be in our practice, and we manage over 2,000 medical cases here. We don't even count the consults in there. we are very, very reluctant to handle this on ourselves without getting one of the doctors at Oklahoma City, whom we know very well, to, hey, come on, take a look at this with us. Let's make sure we're on the right page and make sure we're not missing anything. So, like I said, the AMI guide does allow for issuance of these adjustment disorders in the field by the local AME, but it means the condition must be stable, resolved, no signs and symptoms, the diagnosis is accurate. The medication, if it were used, could not be used for more than 6 months, and they need to be off of it for that 90 days. We need great documentation from the treating physician, and we can get that wrong. And like I said on the previous slide, we like to make sure someone else is taking a look at it before we go ahead and issue, or we issue in concert with Oklahoma City. Now, I'm going to give you a case study here. This is real live. This is not contrived or a hypothetical. This actually happened. So we had a young airman who was a graduate who started out with a regional. Fantastic, doing great. And unfortunately, the pilot, who I was friends with on Facebook, started complaining about the work pace and started posting problems on social media about the high stress load. You know, they got through ground, they got through the sim, they got out on OE, now they're an FO, you know, a junior FO out there, and they were complaining about it. So we actually heard about it from concerned others who were friends of him, who were also following him on Facebook. And at the same time, we found out that he had been started on medication, that he had consulted a primary care and started out on antidepressant medication. Great so far, we're doing good. So we contacted the airman and said under CFR 6153, hey, you've got to self-ground. Now, in this case, the medical was not surrendered. We just had the airman self-ground, and we contacted the treating physician. We discussed it with the treating physician. They were very confident of the diagnosis. Sharp primary care doctor. Airman was having monthly visits with him. He had been started out and was stable on his medication. We were getting monthly reports from the primary care saying how he's doing. Fantastic. After about 5 months, the primary care said, hey, you know, I think he's over the hump here. We're going to stop the medications, but we're going to still, just be on the safe side, we're going to have him in for counseling, for psychotherapy with one of the providers, just to make sure he's doing okay. So great. So 90 days after the medication was discontinued, we bring the patient back into the primary care, and he does a couple of the screening exams, screening and depression exams, their screening tests. In this case, there was the Zung and what's called the PHQ. There's a lot of these out there. And basically told us, hey, yeah, everything is going good. So with that, we got that information from the primary care and the counseling center, who was also forwarding it to it. And we got it into Oklahoma City into their document imaging system, which is called DIWS. That is the FAA's workflow system. Shortly after, we got a phone call. We got a new exam on the youngster, and we did a telephone conversation basically with one of our buddies at Oklahoma City, and he said, yeah, we think it's okay. Let's issue him a time-limited certificate. So the airman gets back to flying status on a 1-year medical. All right, why a 1-year medical? Because we aren't just going to say one and done on this. We want to see how he does a little bit over time. So put him on a 1-year special issuance. The next year, got repeat visit with the primary care. Everything is going fine. The counseling center is saying he's doing great now. So at the 1-year point, we got the documentation together. We got it into Oklahoma City, and the 2nd-year medical on that, he gets issued out what's called a normal duration certificate with eligibility letter and warning. Okay, so what does that mean? So it's a normal medical non-special issuance. The eligibility letter, a portion of it says, we've reviewed your information. We find you eligible to hold a normal duration medical certificate. The warning is, obviously, if this comes back for whatever reason, you got to promptly report it. And I haven't heard from this thing. I think he flowed to one of the majors at this point. So I think this particular young gentleman is now, I'm sure by now he's probably a mid-seniority FO with his airline, probably a couple of years from captain upgrade. All right. So just a couple other things, and then we'll wrap this up. So when it's dealing with FAA standards versus the medical community's standards, we get this question all the time. Oh my God, FAA makes up all their own rules on this, and they make up all their own diagnoses, and they don't follow the clinical standards. Well, actually, in most cases, nothing could be farther from the truth. The FAA tries their best to follow the clinical standards for cardiac conditions and a bunch of different conditions as well. That has led to FAA medical standards to liberalizing pretty dramatically over the 20 years I've been in flight medicine. Actually, 21 years now I've been in flight medicine. Basically conditions which are absolutely showstoppers now aren't even special issuance. They fall under this a couple different programs called AME Assisted Special Issuance, or AASI, and certificates AMEs can issue, or CACI. The best example of that is probably diabetes. When I started out in flight medicine, if you were anything other than diet-controlled diabetic, you're done. You're not flying. Okay, only diet controlled. Now we've not only got oral medication controlled diabetes and insulin required diabetics can fly with a third class. Now we've got it so that insulin requiring diabetics can actually fly with a second and first class. And that program's a couple years old now. We have 4 of those insulin requiring first classes. There's a lot of, trust me, there's a lot of documentation on that. Those are a lot of work. Other things that have happened is reduced wait times between the time of the medical event and the medical certification, where, for example, in many cardiac conditions where there was a wait time of 6 months, minimum 6 months, in some cases that's down to 3 months, and for third class, it's actually in some cases it's down to no wait at all. You can reapply for the medical. For example, if you have a stent as a third class airman, you don't have to wait at all. You can repeat the stress test and go after your third class medical right away. Also, new panels. FAA has created new panels to try to look at cases individually, and also for the purpose of revising standards as we go along, for the purpose of trying to meet current medical clinical standards. Used to only have the cardiology panel. Now we have the cardiology panel. We have the neurology panel. There's a neuropsychology working group. So basically, FAA is trying to get panels of experts for the purpose of working through these cases. And because of the explosion, literal explosion of current medications, particularly in the chemotherapy realms, the FAA actually hired a doctoral pharmacologist for the purpose of getting through these medications, which are literally coming at us day by day by day. So Dr. Vicky Chu was hired for the purpose of doing that. Okay, a couple other slides. Now talking about one particular area where the FAA does have different standards than the medical community, has to do with alcohol abuse. We'll talk about that in a second, but the FAA standards for alcohol abuse and alcohol dependence are different from the medical communities. We get that argument all the time. Hey, my doctor says I don't have a dependence problem, but FAA says I do. And the reason for that is because FAA has different standards on that. All right. With that, believe it or not, I managed to get through this, and I don't know how many minutes I used, but I'm going to stop the share. And Ryan, if there's any questions, I'll be happy to take them.
I love it. That's fantastic. Thank you for that. For the participants, any questions? If Doc, can you put your email address back up, that back slide, so they can see it? And if they don't have anything right now, they at least have your contact information.
Let me see if I can do that. Let me see what the questions are. All right, so we got that, and just a little blurb about what we do, which didn't get on this particular slide. So we're complete service as far as aeromedical support. We're in-flight medical support, ground medical support. We also have our own line of medical kits for aircraft for 91 and 135. We also, and by the way, we're a lot less expensive than our competitor in that. If basically if price is an issue, we try to keep the price reasonable for our clients. We also have a high altitude lab at Western Michigan University for those of you who are want to do hypoxia training for your ISBAO compliance. So basically, if it's aerospace, medicine, consulting, and the like, that's what we do. We consult for one of the big unions, airline unions, and we do a lot of work for ALPA and the like as well. So you're always welcome to contact us either through the email there or through our phone number. We are 24/7 ops, obviously, so you're always welcome to contact us at any time.
Let's see. We got one question. Were you going to discuss the German case?
Yeah, the German wings case. Yeah, I actually, in the interest of time, I pulled out a couple of the slides. So the deal there was Andreas Lubitz, who was the FO in the German wings, basically murder, suicide. He had some problems in the United States. He came in for training and was training in the Southwest, and he was actually under special issuance with the FAA, but had been released to a normal issuance. Now, the bottom line as far as the problem with German wings is the German law at that time did not provide a mechanism for the provider who was seeing him and said, there's no way that this guy should be flying. He was basically, he was inordinately concerned over his vision and thought he was going to be grounded, and the provider who last saw him didn't think he should fly. Unfortunately, that word didn't get to the German authorities, and the accident happened after that. It is my understanding that the German laws were changed after that to provide for a mechanism whereby someone could report if there was an at-risk pilot. We do have that mechanism, that we do have that hotline, which can be anonymous in the United States also. And by the way, I've had some anonymous phone calls from psychiatrists literally in the middle of the night. Now, what did we do with that information? It was this. So I and Dr. Snyder from AMAS, we were invited to come to Washington as far as the Aviation Rulemaking Committee was concerned. And the conclusion of that was basically 4 areas that we needed to make sure that we were doing better. The most salient portions of those were, one was cockpit procedures. And the cockpit procedures in the 121 community in the United States are different than what were in the German wings. In other words, there would have been no way that Anders Lubitz could have been in the right seat of that Airbus by himself behind the door. The U.S. carriers generally require at the very least, a flight attendant to be in the cockpit, so there's a different level of security. And I'm sure you've seen some of them where if somebody's got to go to the bathroom, actually one of the galley carts is actually pulled across the entrance. I believe that's Delta's mechanism for it. So that was one thing. Number 2 was us, the AMEs. Now, I come from a military background, a squadron medical element. I've done support for KC-135s. I also did space shuttle support for 10 years out of Patrick Air Force Base. And we learned in our community as a squadron medical element, you get close to your pilots. You gain the trust of them. I'm lucky. I've been a pilot longer than I've been a physician. So it's kind of been easy to do for me. But you got to get close to your pilots. You got to get the trust there. So if you see a change in the behavior, you know that you don't necessarily need to report it to FAA, but if you don't mind, I'll give you one example. We had a 121 carrier, nice guy, super nice guy. His wife had a very serious illness, which was going to be terminal. And he always used to bring her to his appointments with her. And it was a tragic situation because she knew she wasn't going to live. So ultimately, she died. And he tried to come back to the cockpit too early. He came in for his first class exam and said, "What are you going to do?" I said, "I'm going to go back to work." It's like, the hell you are. Yeah, I mean, it just mentally, he was not in a good place. And luckily, I knew a couple of his chief pilots. And I got on the phone and got a couple of his cohorts, his peer pilots, and I think it was one of his chief pilots too, and said, "Hey, you got to get over to the office. You guys got to get with this guy. His head's in a bad place." And to their credit, they got over like instantaneously and helped him out through their EAP program. And then ultimately he did go back to flying when his head was back on straight. I mean, we are horrible doctors. I could tell you, I won't, but I can tell you the story for when I was going to fly our aircraft after coming off of a military trip, and I had gotten sick, and I had to have my squadron commander tell me, "You aren't flying yourself." And I'm sitting there thinking, "You're right. This is really stupid. We make terrible physicians to ourselves." The other aspect was the EAP programs, and I already mentioned that. Develop, whether it's in your company, your 135 operator, your FAA, your FBO, whatever. Make sure you develop a good EAP program, and also make sure that your employees have got a mechanism that they can go to that's well defined, so they don't have to struggle if they have a problem. They don't have to figure, "Oh, who the heck do I call?"
Right.
Make sure that that's there. And those are kind of the big rocks issues that we took a look at, which were recommendations, which we've stressed to all the carriers.
Very interesting. Well, Dr. Pinnell, thank you so much for your time and this fantastic presentation. And again, I hope everybody listening in currently and in the future on this they have questions to reach out to you directly. Reach out to your team, and let's not keep putting our head in the sand, right? We all are human, and we need to address these issues, and again, to maintain this amount of volume and the positive things that are happening in our industry. So
absolutely. And Ryan, in one of the magazines, I think it's a couple years back, you'd have to go back through some back issues. There's a lot of operators out there who do not have in-flight support of their aircraft. They just don't feel the need to have it. There's a nice article that we put together on what is an in-flight medical emergency. In other words, if you're two up in the cockpit, you got nobody to call, and you got to make a decision whether to divert or not. We've got an article in the NATA magazine on what is a medical emergency, what says you need to divert right now, what can you probably continue on, and it's just a good little primer. It's not designed to make doctors out of you, but it's just good to have something in the back of your head on what's alarm signs, which says, what should I have been on the ground 5 minutes ago? I'd strongly suggest if you can go back in your issues, take a look at that. It's an easier 5-minute read. It would be helpful for you.
fabulous. Dr. Pinnell, thank you for your time.
My pleasure. Have a good one. Fly safe.
Take care. Be safe, everybody.
See ya.
Bye-bye for now.